Welcome back, everybody. We are now going to hear a lecture from Dr. Appel on the update of treatments of lupus nephritis. Jerry?
Said. Okay, so lupus nephritis, which is one of my favorite topics, is a disease that has changed all the time. And you heard a couple of people comment about it earlier in the day and saying triple therapy, why do we need triple therapy, etc. I'm going to go through that and explain. So we'll look at the new guidelines, which there are many of. We'll look at the new treatments, and we'll think of the new challenges with this disease. My conflicts of interest are still the same. I still have no major stock holdings. So, lupus nephritis, is it a rare disease? So it's estimated that between 200 and 300,000 people have lupus in the United States. About 45% of the lupus patients will have lupus nephritis, and of these, about 70% will have bad disease, focal proliferative, diffuse proliferative, or membranous. Nevertheless, we spend a ton of time thinking about lupus nephritis because if you take those patients, 40 to 60% will develop CKD and 15% will reach end-stage kidney disease. And if you think you're doing much better than that, then look over your patients again, because even in the best hands, people progress all the time to end-stage kidney disease for many different reasons that we'll talk about. So, what are the risk factors for progressing? If we say 15% are going to progress, can you pick them out? Well, some things are obvious. Reduced GFR at baseline, nephrotic range proteinuria at baseline, hypertension turns out to be a risk factor at baseline, probably because it's related to the others. If you take males, they only make up 10% of the lupus population, but they always do worse. The pediatric group, again, a small group, but it always does worse. You can think of many reasons why that might be. You've got to take care of the kids and their parents as well, and compliance and things. And some people of African American descent, because of ApoL1 risk genes, do worse. People with a lot of flares of the disease, always a bad factor here. People with a lot of chronicity, especially if it's with activity on the kidney biopsy, crescents on the kidney biopsy, a lot of tubulointerstitial inflammation, which leads to fibrosis. Many of these things are obvious. Likewise, what leads to flares, which are a bad prognostic finding? Younger people, males, again, the same thing, shorter duration of treatment, incomplete response here, not using hydroxychloroquine, which now most of the patients should get, and leaving people with activity and not stopping in terms of treating them in terms of this, that if they're still active. So these are two studies. This one at Columbia, this one done at University of Miami. They showed the same thing. It's a study that we did on 129 patients with either focal proliferative or diffuse proliferative lupus nephritis. Now we'd say diffuse endocapillary proliferation nephritis, but diffuse proliferative is easier to say. In any case, if we looked at racial background over time, the whites did better than the blacks or Hispanics over 5 years in terms of outcome, in terms of not reaching renal failure, etc., or doubling their creatinine. So we looked at this and we were able to determine what part was socioeconomic and what part was genetic biologic. And you can do this in New York by looking at the zip code that somebody's in the New York, in the tri-state area. And the zip code tells you how much education they've had by putting the zip code in, how much money they have in the bank, whether they have stock, etc. It tells you everything about them. So anyway, we found it was a split between those. Gabe Contreras at the University of Miami looked at 213 patients. He found the same thing. If you were white, you did better than if you were Hispanic, and you did better than if you were black. And again, part of it was socioeconomic, part was biologic. Now we know a little bit about the biologic part now. It's easy to guess what socioeconomic factors are in there, but nevertheless, blacks were doing worse than whites. And you had to control for this in almost every study of the treatment of lupus nephritis, which now they do in terms of looking into this. So one other thing that's important to realize is that if you look at ApoL1 risk genes here, Okay, the risk genes are G1, G2, G1, G1, or G2, G2. The only people who have those genes are people whose ancestors came from sub-Saharan Africa. Why do they have those genes? They have those genes because they're protective against African sleeping sickness, and they were protected. Now, these aren't old genes. These are like 10,000, 20,000 years old. They're not millions of years old. But you were protected against sleeping sickness. We don't have any sleeping sickness in New York City. We've got a lot of focal global glomerulosclerosis, which has been hypertension attributed, but may indeed be due to these risk genes. We've got a lot of focal segmental glomerulosclerosis due to these genes, and collapsing focal sclerosis is much more common with these genes in both high VAN and co-VAN. Now, it turns out in severe lupus nephritis, the same thing is true. If you have these risk alleles, you are likely to do worse, explaining at least one of the factors, the biologic factor, that why people of African American descent will do worse. Another thing I want to mention before we really get into the data about the newer drugs is the risk of cardiovascular disease. So this is a study from Hermanson's study from Denmark, which looked at a large number of lupus patients. So if you took patients with lupus who had no nephritis, they had no kidney disease, and used age and gender matched controls, the risk of myocardial infarction just from lupus was over twice as high. But if you took people who had lupus nephritis, the risk went up tremendously here over the matched controls. If you look at the rate of cardiovascular mortality, the same thing. Higher in lupus nephritis than the general age and sex matched population, but much higher in people with lupus nephritis. Now, for most nephrologists, this is obvious. If you take people with CKD, they have a cardiovascular risk equivalent of a diabetic patient, even though they don't have diabetes. The rheumatologists know if you have lupus, you have the cardiovascular risk factor equivalent to a diabetic, even though you don't have diabetes. If you add CKD and lupus, your risk goes way up. So it is not unusual to see women in their 40s, early 50s, they're just postmenopausal, that they're having heart attacks and strokes, etc. Things that cardiovascular mortality that you would not normally expect for somebody in a female that age. But again, it's common and you have to think of it. So always tune in to lipid control, blood pressure control, all the routine things you would do anyway, but they're very important in lupus patients and patients with lupus nephritis. So what about biomarkers? I always like to mention urinary soluble CD163. It's a product that is split off from macrophages that, and if it's in the kidney, it's split off and appears in the urine. And it's been touted as a non-invasive marker for active kidney disease. For active lupus nephritis, it's been looked at in ANCA-positive disease as well, and it's actually been looked at in IgA nephropathy recently. So here's a study by a combined Mexican and U.S. group. Brad Rovin is one of the authors here. And what they found is the more activity you had on the biopsy, the higher your level of urinary CD163. And if you had a flare of disease, it went up. And if you responded, it went down. And if you didn't respond, the level did not go down. So the conclusion was that it may be a valuable tool in lupus nephritis as a biomarker reflecting histologic inflammation. This is, again, has been suggested with ANCA-positive disease and also, in IgA nephropathy recently. The problem is that there are studies that suggest that if you have more proteinuria, you get higher levels of urinary CD163, and therefore you have to correct for it. There are others that say the renal insufficiency you have to correct for it. Again, if you start finding these things you have to correct for it, it detracts tremendously from a biomarker. So this has not caught on, even though there are commercial kits available for this. A biomarker that is useful is exostocin. So if you stain the biopsy of a membranous patient and you don't get your PLA2R, but it stains positive for exostocin 1 and 2, Here again, you're looking at this as a proliferative one with membranous components. Same thing. If it stains positive, this has said two things. One is it says this is indeed membranous lupus, even if the person hasn't fulfilled the criteria for the ARA criteria for lupus. If they have exostosin there, they're not an idiopathic membranous, they're a membranous lupus. And the other thing is that in the original series from the Mayo Clinic, they looked at a huge number of patients with membranous lupus, 374. So if you looked at them on biopsy here, that 32% were positive and two-thirds were negative. So not everybody with membranous lupus has it, but if you have the staining, then you know that it's a lupus membranous. The other thing is they found if you stained positively in the whole group, you did much better than if you stained negatively. If you stained in pure class 5, you did better if you had the exostosin, and if you had mixed class 5 plus a focal or diffuse proliferative with it, you did better if you had exostosin. So as a marker, yes, it's panned out. As a prognostic thing, so-so. So here's a study where, again, they looked at membranous lupus patients. 75 of them were exostosin positive, 90 of them were exostosin negative. There was no difference in their treatment here. Complete remissions were the same. Partial remissions the same. Follow-up at about the same time period. Kidney endpoints reached. Relapses. Everything turned out the same in this study. So this did not give you a prognostic edge when you had exostosin positivity in your membranous lupus. Now, a more recent study explains perhaps what the reason. The study is about a year and a half ago. It's again from China. It looked at 283 patients with membranous here, 85% female. What they found is the exostosin positive patients had less chronicity and more activity in association. So if you looked at that, that was what they thought was the explanation here. Here's looking at the lupus activity in terms of this, so if you take the whole picture in terms of this, that the people with the exostosin positive had actually less adverse renal outcomes, but this was probably due to the fact that they had less chronicity and more activity indexes. So given that, again, yes, it may be a biomarker. I think it's best to say, look, if it's positive, this person's going to have, they'll turn out to have membranous lupus. You may have to watch them for a certain amount of time, but they're high risk for membranous lupus as opposed to being idiopathic or one of the other antigens for membranous. So let's get to the crux of this whole problem today. We're going to talk about somebody with diffuse endocapillary or diffuse proliferative lupus nephritis. 28-year-old female, blood pressure a little bit high, weight's 102, she has 1 plus pedal edema, her BU ends up at 28, creatinine's 1.2, which is up for her at 28 years old. Albumin is low, she has 3 plus protein, 3 plus blood in the urine, high anti-DNA, low C3 and C4, and her biopsy has diffuse endocapillary proliferation, diffuse proliferative lupus nephritis, with 22 of 34 glomeruli showing proliferative lesions. And here you see them. Okay. The staining with IIF is what we call full house staining. It has 3 of one kind, the immunoglobulins, IgA, IgG, and IgM, and 2 of the complements. So 3 and 2, full house staining. The electron-dense deposits are found in the mesangium, but many subendothelial. Her activity index is high, her chronicity is very low. How do we treat this patient in 2026? That's our big question. How are we going to treat this patient now as opposed to a year or two ago? So if we look at Kidney International KDIGO guidelines, here they're 2024 again. If you look at things like membranous and minimal change, you're talking about guidelines that are 4 years old, 5 years old. These are a year and a half old. So the different things that's different than before, the older guidelines are 1, less steroids, lower the dose of steroids. You can still use pulses, but then go down to lower levels of steroids. And we'll tell you why you can do this. I mean, there's very good evidence that it works. You could either get a calcineurin inhibitor after the steroids and with steroids. You could either get a calcineurin inhibitor with a mycophenolate or myfortic, one of the two, mycophenolate analog. You could just get mycophenolate analog. You could just get cyclophosphamide for up to 6 months, either using the Lupus regimen, 500 IV every 2 weeks for 6 doses, or you could take 6 months of oral therapy. Or you could get belimumab with mycophenolate or cyclophosphamide. So you're looking at triple therapy with the prednisone in these two, triple therapy, prednisone, and these two or these two. So it's both triple therapy. These are double therapies. Again, less steroids. You have a bigger choice of initial therapy, and it includes both belimumab and voclosporin. Now, again, that's 2024. There's no mention of obinutuzumab, which we will come to. So if we look at the American College of Rheumatology guidelines for 2024, here's their overview. For diffuse proliferative disease or focal proliferative disease, plus minus membranous, whether you have a membranous component or not, first line, triple therapy. Use one of those triple therapies, steroids, trying to taper down, definitely less than 5 milligrams per day by 6 months, with either mycophenolate analog or belimumab, and here you could use or a calcineurin inhibitor. So here you've got triple therapy, here you've got triple therapy, or you could use glucocorticoids plus low-dose cyclophosphamide and belimumab, triple therapy. Dual therapy only if triple therapy is not available or not tolerated. We'll talk about membranous later, but why are they recommending triple therapy? We'll come to that. So if you look at EULAR, remember EULAR is the old name. It was the original name. EULAR was for it was European League for Arthritis and Rheumatism. The newer name for this is the European Alliance of Associations for Rheumatology. But regardless, it's the same organization here, which is all the rheumatologists in Europe. Kidney biopsy for all with evidence of kidney disease, which includes proteinuria over a half a gram a day or over 500 milligrams per gram of creatinine. Again, lower levels than we did before for glomerular hematuria or unexplained low GFR. More aggressive on biopsy. The goal, reduction of proteinuria, 25% by 3 months, 50% by 6 months, and a urine protein creatinine ratio less than 0.7 by 12 months. IV pulse methylprednisolone, followed by steroids, reduction to less than 5 milligrams per day by 4 to 6 months. And for active lupus nephritis, again, triple therapy. The same things, steroids plus MMF or cyclophosphamide, that's 2 drugs, with either belimumab or steroids plus mycophenolate plus a calcineurin inhibitor, which is usually voclosporin, or steroids plus MMF plus obinutuzumab, which is now FDA approved as well. Maintenance therapy for at least 3 years. That's their current guidelines, 2026. So why do we need triple therapy? Let's look at some of the best studies. One of the studies that led to the use of mycophenolate, it was probably the major one that did this, is the ARM study, which at 6 months showed if you compared mycophenolate, cyclophosphamide, and again, this is double therapy just with steroids. If you looked at complete remissions, partial remissions, no remissions here. At 6 months, cyclophosphamide was about the same. The switch to MMF was because cyclophosphamide was more toxic, not because MMF was more effective. If you follow these people longer, many of these partial become complete remissions, and some of these do, but you're still left with many non-responders. Now let's look at a more recent study, the LUNAR trial. The LUNAR trial looked at MMF plus prednisone with or without rituximab, okay? So it's with or without triple therapy here. If you look at it here, here's complete remissions here. This is the rituximab arm here. Here's partial remissions. Here's no remissions. This is at a year, okay, even with triple therapy. So again, there are many patients who are not responding. If you use double therapy, there will be many more non-responders than triple therapy, as I will show you from the studies that led to the new drug's approval. So we're going to talk about the newer agents that are approved for lupus nephritis, okay? Rituximab is not FDA approved for lupus nephritis. And I think since the fact that obinutuzumab is and is a better drug, I think it's going to be replaced by obinutuzumab. Belimumab is approved for lupus nephritis. It's been approved for lupus for over a decade, but now it's approved for lupus nephritis as well. And voclosporin is a new calcineurin inhibitor, which is approved for lupus nephritis. It's very hard for an insurance company to say they're not going to give you a drug that is FDA approved for that drug, and they want you to use something that is not FDA approved. So again, ACR guidelines, triple therapy. KDIGO guidelines, triple therapy. EULAR, using combinations, again, comes out to triple therapy. And again, it's not just which triple therapy, it's that we weren't doing well enough with double therapy. There are too many people who are not responding by 6 months, and that's your goal, is to get the proteinuria all the way down by 6 months. So let's talk about belimumab now, Benlysta. So earlier today, I talked about IgA nephropathy, and I talked about drugs that are blocking APRIL, the cytokine that causes B-cell proliferation and prevents B-cell apoptosis, and those drugs that block both BAFF and APRIL that do the same thing. They block the cytokine that leads to, B-cell proliferation and lead to B-cell apoptosis. So here we're talking about a drug that just works on BAFF BLyS. BAFF is B-cell activating factor. It's the same thing as B lymphocyte stimulator, the exact same molecule here. So what does BLyS do? BLyS binds to B cells and leads to immunoglobulin production. It binds to B cells, leads to increased survival and increased inflammatory and autoantibodies production here and transformation. This is all through plasma cells. If you have belimumab, it binds to belimumab is an antibody that binds to BAFF, BLyS, whatever you want to call it, prevents its binding here, and the B cells undergo apoptosis. That's the mechanism of action. So what's the data? The data is one of the largest and longest studies that's ever been done in lupus nephritis. So this trial here, the BLyS trial here, looked at 450 patients, 225 in each arm here. The patients were divided into those that got belimumab added, those that got placebo added. They added them to both of the standards of care. Standard of care here being cyclophosphamide or being mycophenolate, okay, for induction. And then for maintenance, the cyclophosphamide group got azathioprine. This is by the Euro-Lupus regimen. The MMF group continued on MMF. In this arm, they got placebo added to either that they did not get the belimumab added on, they just got the cyclophosphamide by Euro-Lupus, switching to Imuran for longer term, and here they got MMF with MMF. So you've got 4 different arms here in terms of this, but 2 are getting belimumab, 2 are not. The follow on these 450 patients is 2 years. You can't say it's too short a study. So what were the results? A renal response. A renal response here was said to be that if the proteinuria got down to the low level by X amount of time in terms of being 0.5, you wanted to get the urine protein creatinine ratio all the way down You couldn't use any other immunosuppressives along the way. So you wanted a good response in terms of this, but that was the response that the FDA said they would approve the drug that for lupus nephritis. Remember, it was already approved for lupus a long time ago. Anyway, by 2 years, there was obviously a better response here, statistically significant. Even by 1 year, there was a better response, statistically significant. If you looked at complete remissions, again, significant by 2 years here, and renal-related bad events or death, higher in the standard of care group. So adding on Benlysta to standard of care, whether it was cyclophosphamide or whether it was mycophenolate, did much better over time. The other thing you can say is that in the Bliss lupus trial here, that if you looked at flares after the first 6 months, they were much higher in the standard of care group than they were when Benlysta was added to standard of care. Much lower risk of flares. If you looked at GFR slope over time, the loss of GFR was significantly less if you added belimumab, Benlysta, to this group here as opposed to placebo. So again, standard of care, this was not a study where they gave you placebo in one arm. They gave you the routine standards of care and they added on the belimumab and it did better. Now, the one place that's been criticized is that it's not clear that the medicine worked that well if you took it in patients who had class 5, that is membranous, pure membranous, or people with very heavy proteinuria. This is complete remissions here, but again, if you had higher levels of proteinuria, you can see it wasn't clear that the medicine worked that well. Now, so some people say that they don't want to use belimumab as an add-on if you have nephrotic range proteinuria, but it did work in many of the patients. So here's an analysis here, a subgroup analysis, okay, where they looked at the MMF patients. These are belimumab, this is placebo. The MMF patients had less than 3 grams of proteinuria. They did significantly better. If they had over 3 grams of proteinuria, they still did better. The response rate was better than placebo added to standard of care. If you looked at cyclophosphamide, they did about the same with less than 3 grams. They did not do as well if you had added cyclophosphamide in terms of this. But the numbers are very small here. You're talking about 50 patients out of the 450. So again, small numbers because not that many people use cyclophosphamide. It was all being used by the Lupus regimen in Europe. So again, it's not clear that belimumab does not work for that population. One thing we can say is a recent study looked at biomarkers that might predict what was going to happen. And the only one that really came out important was how many naive B cells they had initially. Well, we don't measure the naive B cells, but the urine protein creatinine ratio at 3 months was very predictive of who was going to respond over time. So again, they confirmed something that we knew before, that the urine protein creatinine ratio is very important. Now, another study that's very recent that I want to mention is this is a prospective randomized trial here. In this prospective randomized trial, it was a small study, but it was a multi-center trial here. They gave therapy, preemptive therapy. If the anti-DNA antibody went up, they increased the prednisone and they gave increased MMF or azathioprine and then rapidly decreased it. The control group, they ignored the anti-DNA antibody. They just treated whether the renal disease itself looked like it was getting worse. So what happened in this study? Preemptive group here, looking here over time, that this is the risk of total flares here in terms over time. This is the group without a flare. Preemptive therapy didn't have any flares. You treated the anti-DNA and they did fine. Here's the group that got placebo. If you look at renal flares, again, none. Here's the group that got placebo. It may be that we should focus a little more on the anti-DNA and the complement. Now, usually I say if the anti-DNA is high, if the complement is low, just see them more often. Just make sure you see them not 3 months out, like I usually follow these patients, but maybe a month out, repeat the labs, see which way they're going. On the other hand, you can just say, look, this is the first trial that's looking at preemptive therapy like this, and it does show a positive result. And of course, this is just published this year. Well, let's turn to the second medicine. So belimumab has been used for a long time, by the way. It's been used in kids. It's been used in, both subcutaneously and intravenously. It's a drug with many advantages because it's been around for so long. So the Aurora study looked at voclosporin, a unique analog calcineurin inhibitor that does not need to have drug levels measured because it's so consistent when you give a dose that what you're going to get for a drug level that all you do is you adjust it based on the serum creatinine. And in this study on 357 patients, they're all focal or diffuse proliferative patients here that you're looking at here, that if you look at them over time in terms, focal, diffuse, or membranous, but complete renal response. Here's placebo. Here's the Voclo. Okay. And if you looked at here is that's a year. This is half a year. You still had it there. Serious adverse events not increased. So adjusting the calcineurin inhibitor based on the rise in creatinine seemed to be very effective here. And again, this is in multiple centers across many countries. Here again, you're looking at partial responses. Here's the Voclo. This is at 6 months and at 1 year. Here's partial and complete responses here. And again, better in both. Now, the most amazing thing about this study, I think, is the efficacy that you found in lowering prednisone. Everything we're doing these days in nephrology is trying to get down on lower doses of prednisone. We do this in transplantation. We do it in ANCA vasculitis. We're doing it in lupus. Here, 80% of the patients, whether they got the drug Voclo or they got the placebo, able to taper their steroid dose to less than 2.5 milligrams a day by 4 months. They started at 20 to 25 milligrams, not the 60 milligrams that we always used to start before. So you could get a pulse of solumetrol, a couple of pulses in here, but you start at a low oral dose and go down. You're going to get less steroid side effects if you do that. So you know it can be done. This was done in the placebo arm and is also in the arm that got the voclosporin. What about long-term safety with a calcineurin inhibitor? So here, if you look at renal function here, okay, over time, it's a little bit lower, here in the Voclo group. It always is, of course, with the calcineurin inhibitor. You always expect the creatinine to go up a little bit. But actually, if you get out here after 30 months, it's actually equivalent because the other arm is doing worse clinically. And if you look at proteinuria, it comes all the way down and stays down all the way out here again, out to this long-term study here. And complete renal response, again, better. So again, looking at long-term data, it's pretty good here with this drug. Rituximab has a checkered report here because the study, the LUNAR trial, which I mentioned before, it was a good, well-designed trial. Everybody got the same dose of prednisone. Everybody got the same dose of mycophenolate. This group got rituximab versus placebo. It turns out the end up was that it wasn't statistically significant. Even though there was a trend to the rituximab being better, it wasn't statistically significant because there were only 140 patients in the study. We told them they were going to need more than that in the study, but they said that no, that's all they needed. So now we have obinutuzumab. Obinutuzumab is a fully humanized molecule. Remember, rituximab is chimeric. It's half mouse, half human. So they're both anti-CD20 monoclonal antibodies. It's been FDA approved for treating. Obinutuzumab has been FDA approved for treating CLL and follicular lymphoma for a long time now already. It is glycoengineered to be much more effective in antibody-dependent cytotoxicity in terms of B cells here. It leads to much better improvement in terms of by depleting B cells. Here you're looking at percent of B cell depletion. This is a rheumatoid arthritis study. Here's rituximab, here's obinutuzumab. Now remember, this is the same company. They just have a monoclonal now that's humanized. Here's lupus patients. The same thing you will find over time. So it's been superior to rituximab in a number of studies. Very few are controlled head-to-head, but most of them are comparing it to other things like calcineurin inhibitors. So here you're looking at a trial of obinutuzumab here with mycophenolate and steroids. This is triple therapy again in proliferative lupus nephritis, the NOBILITY trial. Here you're looking at complete remissions. Here's partial remissions. Now you're up to 50-something%. Again, here is the placebo arm with mycophenolate and steroids alone. If you look at, that's week 52, here's week 76, here's week 104. Again, you've already got over 50% now are getting, and many are getting 41% getting complete response, which is very good here. So a very successful run here. This led to the trial in the patient trial with obinutuzumab for severe lupus nephritis. So 271 patients, 1-to-1, OB versus placebo. Everybody gets mycophenolate and low-dose prednisone, which was the standard for the U.S. most of the time. And if you look at terms of this here, the major endpoint was getting the protein creatinine ratio down to less than 0.5, GFR within 85% of baseline, and no intercurrent bad event. Here you can see the study, OB, 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 OB. So that's baseline, 6 months, 1 year. Okay, your different arm only got one dose at 1 year, and here's the placebo arm. So this group only got one, but again, they combined them because they came out about the same with one dose here or two. And here's the complete response rate, significantly higher, 46% with OB, 33% with the placebo. Serious adverse events, it looks like it's more, but all of the serious adverse events were due to COVID. They did the study during the COVID period, and people got COVID and they got sick. So again, the FDA took that into consideration. If you look at C3 levels, they come up faster with OB. C4 levels come up better. Anti-DNA drops more. And if you look at B cell depletion, here's the control arm, here's B cell depletion here, you're looking at weeks now. So if you go out to, something like 52 weeks here, this is, I think, 50 weeks, you still have 94% depletion here, and as you go out further and further. So again, very effective. The other thing is if you look at what groups it was effective in, the vast majority. Now, males didn't seem to show that, but again, the numbers were very, very small. The number, when the group's numbers are very small, that's when the lines get bigger and they go all over the place. The vast majority of OB was better. Now, an interesting thing is that this is a paper that just came out recently in the New England Journal, much more recent than the last study. This is a study that looks at active lupus. So the study on active lupus nephritis was published before the study on active lupus. But nevertheless, if you look at it, this is Rich Fury and the rheumatologists that work in this group here, that the OB was better in terms of preventing for bilag flares here, for keeping the SLEDAI score low here. Everything, again, was positive for the OB. And here you're looking here at the percentage of patients. This is normalization of C3, normalization of C4, that anti-DNA antibody here again, and here's the patients with B cell depletion all up there. So whether you're looking at lupus or lupus nephritis, it is effective. The nice thing is, even though it's more expensive than generic rituximab, it's not phenomenally expensive. All of these new IgA drugs are unbelievably expensive. But here, because it's an older drug, it's been approved for treating tumors for a while already. The course of treatment is just not that expensive compared to any of these other newer drugs. So how do I treat focal and diffuse proliferative disease? I evaluate the patient. I start with triple therapy, steroids, MMF, belimumab, or calcineurin, or obinutuzumab. So it has MMF and it has one of these other medications as a third drug. That if they're already on mycophenolate and steroids, here that I add a third drug, belimumab, Voclo, or obinutuzumab. If they failed prior therapy with MMF, I consider cyclophosphamide or going right to rituximab or nowadays obinutuzumab. And if resistant, I consider rituximab or obinutuzumab. Now, what about maintenance? So the ALMS trial showed that mycophenolate was superior to azathioprine for maintenance. They couldn't show that in Europe using cyclophosphamide, a background in terms of this. But nevertheless, in terms of this, it's pretty well clear that in terms of this study, it was positive. Many choices: mycophenolate, azathioprine, belimumab, and MMF, or an analog, belimumab plus azathioprine, calcineurin plus mycophenolate. You've got multiple choices, but again, with triple therapy, one of them. What do? I make sure the patient is in remission first. If they are in remission, I consider former therapies. I prefer MMF to azathioprine, but I have no problem using voclosporin with MMF, using very low-dose steroids, or belimumab plus azathioprine, or MMF plus low-dose steroids. There's less data on calcineurin inhibitors and obinutuzumab, but they certainly can be used. Maintenance should be 3 to 4 years here. If they're planning pregnancy, I go azathioprine and TAC over MMF and voclosporin. And there's little data on belimumab and obinutuzumab. You'd think there would be a lot of data because it's been around a long time, but there just isn't a lot of data. So it's AZA and TAC for pregnancy. And finally, the management of membranous. Don't read this here because it's all big here, but I'll tell you. Here's pure class 5. What did they recommend? Triple therapy. Alternative, triple therapy. Again, the same thing for membranous. This is how I treat membranous. Membranous with focal or diffuse proliferative, I treat it as focal or diffuse proliferative. I forget about the membranous component because it'll get better with the vigorous therapy. For isolated lupus membranous with a normal GFR and low proteinuria, I use ACE inhibitors, ARBs, hydroxychloroquine, and in some patients, SGLT2 inhibitors. For membranous with heavier proteinuria, I consider the former therapies, the risk of delaying therapy, cosmetic concerns, etc. But again, in most of these, I prefer calcineurin inhibitor plus MMF plus low-dose steroids as initial therapy, or OB plus MMF and steroids, because again, OB looks very good in terms of membranous nephropathy, idiopathic membranous nephropathy. Now, just a word or two about things that are coming. CAR T cells, here's a study in the New England Journal. This was 2024 here. It looked at 15 patients with autoimmune disease. Here you can see the SLEDAI index, the anti-DNA, the C3, urinary protein came down, looked very good. Here's another study that was in the back of the New England Journal and in letters to the editor in October 2025 using CAR T cells. I just want to point out, proteinuria here is in green. They give you all the different features. Proteinuria didn't change here. Again, now it wasn't very heavy, but it didn't change. Here, it went up a little bit. You got out here. And again, this one didn't. We need data in lupus nephritis on CAR T cells in the refractory patients before we go on the other data. So will BAFF/BLyS blockers that are used for IgA be effective? Phase 3 trial of telitacicept. It worked essentially. Reduced proteinuria, had a better serologic response in 335 adults, but it's in China. It's not being studied in the United States in any large numbers at this point. But it probably means that atacicept and povetacicept and sibeprenlimab will be tried in this. So the conclusion of all this is we have new and better medicines. We have better goals: reduction of proteinuria, preservation of GFR, biopsy early, reduce the steroids here, that we have large controlled blinded randomized trials here. Not everybody's going to benefit from obinutuzumab, belimumab, or Voclo, but think triple therapy. We had lots of failures before. Obi, before it was only for resistant patients. Now it's going to be used for many more. And what we really need is, it's like IgA, we need comparative studies of different triple therapy regimens. We still need new medicines, but first we need these controlled trials of comparative medicines. And I'll stop now. That, as I like to say, I've already told you more than I know about the subject.
As before, we're going to save the questions until the end of the session so I can introduce the next speaker.